Yes, good evening. My name is Jim Greenblatt, and I'll be speaking with you tonight about, I think, an incredibly important topic. I'm trying to change how we think about eating disorders, weight management, to a concept that I call appetite control. And we're going to try to understand a little bit about appetite, and particularly some integrative therapies, and also I will discuss a little bit about medications tonight. Part of the reason I believe this is an incredibly important topic because for too much of our energy trying to understand weight loss, we're, I believe, in an endless cycle of making patients feel guilty and shameful about how they can't just change their diet and exercise. And in my world, running an eating disorder hospital, I have patients who've attempted suicide because of that frustration, and I have patients attempted suicide in the middle of out-of-control binges because they're unable to stop. So I want to shift the discussion to a biological understanding of appetite, which means we'll have a biological solution. And I believe integrative therapies can be incredibly helpful. We eat because we need to provide energy for our cells, and hunger is not always the prime motivation in our society. There's lots of complicated neurocircuitry that is related to how we sense food and eat, although what is clear since there's such a powerful drive, there needs to be an incredibly powerful reward system in the brain. And the concept that I'll share with you, which is not new, certainly been in the lay press and the self-help groups for a long time, is this concept of food addiction. And when I use the term food addiction, we're talking about a concept of neural activation that looks like the brain chemistry of those dependent on drugs of abuse. This is a study published a few years ago in the Archives of General Psychiatry, a very reputable journal. It was able to demonstrate that there were similar patterns of neural activation in patients with who were shown, obese patients who were shown food, and it was similar to those that had drug abuse neurocircuitry. The interesting part here, we'll talk a little bit about later, besides an elevation in the reward circuitry in response to food cues, there was a reduction in activation of the inhibitory regions of the brain in response to food intake. And this lack of inhibition, which is a flip side of poor impulse control, I believe is also an important part of the chemistry we'll be talking about. And for any of the major psychiatric disorders, and I believe for the eating disorders in particular, we're always balancing multiple concepts of genetics, stress, inflammation, neurotoxins, and diet. The genetics are not only for major psychiatric illnesses, but certainly genetics of how we metabolize nutrients. And when we talk about eating disorders, we talk about out-of-control appetite. It's like everything else. It's not one size fits all. There are multiple paths to disordered, out-of-control eating. Oftentimes, patients struggle with what we call comorbid conditions. So they might have out-of-control eating, whether it's just binge eating, whether it's bulimia, or a form of disordered eating. But what is often missed is a very significant underlying anxiety disorder, mood disorder, substance abuse disorder, or attention deficit disorder, or OCD. There's increasing literature demonstrating how untreated ADHD contributes to disordered eating, and when you think about it, it certainly makes sense. Those that struggle with impulse control, those that struggle with attention problems, when we chew, when we're using our mouths in that chewing fashion, it does enhance attention. That's why you see many of these kids chewing on their sleeves or chewing on their cords of their sweatshirts. But chewing food also can enhance attention. So poor impulse control, enhanced sustained attention is a setup for ADHD and an eating disorder. We see this particularly in young women and teens. So this another recent article kind of putting together this concept of genetics with emotional eating, and this was a very important study looking at a genetic polymorphism of the serotonin transporter gene. So we have two different forms of this gene, a short form and a long form, and low levels of serotonin activity is associated with a more reactive arousal system, including increased appetite and body weight. And this study showed that adolescent girls showed a much higher incidence of emotional eating if they had that the short variant of the serotonin transporter gene. So again, there's the genetics that we are blessed with the environmental stresses are key components to the development of these disorders. There's an expression called the dark side of food addiction, which is not just the experience of having a piece of cake or ice cream and not being able to stop, which we call a binge. But what happens is the repeated intake of these foods downregulate the brain. Reward pathways become sensitized, and those individuals begin to have the experience of anxiety when they're not consuming those foods. So the dark side of food addiction are those periods when one is not binging, that one starts to become dysphoric and anxious, and early on the cue to eat is providing that sense of comfort. So we talk about the roller coaster of shame, of fear, of guilt. Again, our society is pretty much from the Nike logo, just do it. Anybody should be able to just lose weight, stop eating, exercising, but this roller coaster of disordered eating is a powerful biological mechanism. A couple New York Times best-selling books are coming out. Again, the general public is talking and writing about food addiction. Mika Brzezinski's book on Obsessed, America's Food Addiction, and my own. And again, her point is that being addicted to food does not have anything to do with weight or size. She described, if I eat all this food and then I run 10 miles and I won't gain weight. So again, the general public has been talking about food addiction in self-help groups, whether it's OA or Food Addiction Anonymous, and but the medical profession has, I believe, largely ignored the concept, and I want to try to understand it a little bit. We've talked a lot in previous webinars on how the immune system affects brain function, and when we get sick, we get a cold or flu, our immune system begins to produce cytokines to help destroy the virus, if you will, or bacteria. And that process, what happens when we're sick, we typically lose our appetite. And there's very direct relationships between the cytokines in sickness behavior and the decrease in serotonin. So we know that this enzyme IDO is produced, and this destroys both tryptophan and serotonin. I would say one of the most consistent findings that we get on our patients with binge eating disorder is a state of chronic inflammation. Often this has to do with excess weight and fat, but many times these patients are normal weight and they're in a chronic state of inflammation.
Dr. Greenblatt? Dr. Greenblatt?
Yes.
Is your microphone moving? We can hear you at times, and then it sounds like you're further away. We can't. The audio is cutting in and out, kind of.
Okay, I think because I looked down. Okay. Okay, can you hear me now?
Sounds good.
Okay. So what I want to start the discussion on is the importance of amino acids in the treatment of appetite. And this was a study done a number of years ago in the Archives of General Psychiatry in 1999. And these were patients who have recovered from bulimia. I'm not sure I understand why someone would volunteer for a study if you've recovered from your illness. But what the researchers did is give individuals a tryptophan-free amino acid mixture. And this is really important because the majority of amino acid products in the market do not have tryptophan. Tryptophan, as you know, is one of the essential amino acids. So they were given this amino acid powder, the 12 healthy controls, and 7 hours after the administration of this mixture, there was increased ratings of body image concern and a sense of loss of control following the tryptophan-free mixture. And again, a simple experiment, but very powerful. The follow-up, some of these women had struggled for weeks after this study. And the first point that I've made before is understand the role of nutrition. It's not alternative medicine. We need to understand the chemistry. Here's what I talked about earlier, are asking our patients who are overweight or struggling with appetite to just exercise and diet, and it's not sufficient. So I want to give a couple of important points when we try to help someone learn to control their appetite. And this is, these are scrambled eggs, if you can't tell from the picture. And when I was in high school, a friend of mine's family owned a Chinese restaurant. And a gentleman came into the restaurant before 12. It was right at 11. The restaurant opened, and he was looking for eggs. And he was a regular customer. And they told him that they don't have eggs. And he asked them if they could just cook him up some scrambled eggs. And they did. And he proceeded to come back 3 or 4 times a week for a number of years because he said it was the best scrambled eggs that he's ever eaten. And as my friend describes the story, he describes how they cook the scrambled eggs. And that's with a large scoop of MSG. So the first point that I think is really critical when we understand the concept of food addiction, MSG, monosodium glutamate, is a powerful toxic food additive that is added to many foods. And it does a couple of things. One, glutamate in the brain is neurotoxic. It, when it's outside of the cells, it causes destruction of the brain cell and release of inflammatory agents in the brain, like quinolinic acid. And it also causes what we call leptin resistance, which means the brain cannot properly hear that the body has enough food, and it continues to feel hungry. So MSG is added to the majority of processed foods. There are many, many different names. I don't have it here besides monosodium glutamate, and I would encourage you to look up all the different sources of MSG. And oftentimes, these are the foods that patients are, if not binging on, find it very hard to stop. What's in the literature, food addiction, in the scientific literature has been around for about 30 or 40 years. Scientists have been looking at studies with animals and rats and humans. But again, my point, it hasn't trickled down to the clinical literature. That 5 of the most common foods that do cause physical and emotional dependence are chocolate, sugar, cheese, milk, and meat. And I want to try to understand some of these with you. Some of this you've already heard of. So one of the tests that we've been talking about for a number of years now is the neuropeptides. And we know that consumption of dairy is the protein casein and produces the neuropeptide casomorphine. And gluten produces gliadorphin. Casomorphin and gliadorphin are neuroactive peptides that are morphine analogs and hence have profound effects on brain chemistry. Most of you are aware that we look at this early on in autism. We've seen it in schizophrenia. But I guess what is not commonly understood, which is both intuitive and very common, is the addictive properties of these substances, casomorphin and gliadorphin. Cheese is very concentrated sources of casein, as is milk, but cheese is probably the more common addictive dairy product. Our body breaks it down to casomorphine, and then with DPP4 we break it down further to the harmless amino acids that cross the blood-brain barrier. Without adequate DPP4, with casomorphine is sufficient to cross the blood-brain barrier and have CNS effects. This is a patient that we treated a number of years ago. 16. She was with us at 22, but she started eating flour when she was 16 years old. She became depressed. Currently, the patient was eating between 1 and 2 pounds of flour daily, a maximum of 4 pounds, which means she took a bag of flour, she mixed it in water, and ate the paste. And when we spoke to her, she describes feeling calm and relaxed. Again, casomorphine,
Dr. Greenblatt?
gliadorphin, is morphine. Yes.
The audio is still dropping in and out quite a bit. Do you have a fixed microphone or a headset that you could plug in?
That's what I'm using as a headset.
Oh, okay.
Well, let me... Okay, I'll try to do that. Is that better? Hello?
That does sound better.
Okay. This was a 24-year-old, a 12-year history of eating disorder. And it's important to understand that casein is like MSG in many, many foods besides dairy, certain granola bars. Anytime we're trying to enhance the protein content, we'll add either soy or casein. I've had patients who've started using whey protein powders that said 100% whey but had major sources of casein, and products like COFACTORS is almost all casein. Again, cheese is the most common addictive dairy product, and when we think of foods our patients binge on, it's certainly foods that are high dairy and wheat content. It is known that these foods contribute to addiction. I've seen very little written about in the academic research about the intense, the power of the casomorphin and gliadorphin to create this vicious addictive cycle around food. The test is simple. It's a urine test, a first morning urine, and here's an example. This is the patient with elevated gliadorphin. When we talk about psychiatry, we talk about the measureless medicine. We have no objective tests. We ask a lot of questions and try to get a history and make an assessment and a treatment plan based on those educated guesses. In the case of morphine, gliadorphin is a simple urine test that provides an important clue to food addiction. The next part of what I want to share with you is a little bit about the basis for appetite in the brain, which has to do with both neurotransmitters. We think of serotonin, dopamine, and norepinephrine, but there are really hundreds of amino acids and peptides in the brain that affect appetite. Every medication that we use in psychiatry affects neurotransmitters. When we think about regulating appetite, we have a list of chemicals. These are hard to pronounce names, and we could fill the page with many, many more. And again, these are all peptides and amino acids. But this is what the scientists are doing their research on. This is how we understand the concept of satiety and the concept of hunger. What I will keep sharing with you for the rest of the evening is all of these hormones, peptides, neurotransmitters, and cytokines are all derived from amino acids. So let's try to understand that a little bit. If we take adequate protein in our diet, we have digestive enzymes and hydrochloric acid to break the protein down to amino acids. If these amino acids get absorbed, then we can produce the serotonin, dopamine, norepinephrine, all the other neurotransmitters. What is not uncommon in our patients with binge eating is we do tests for amino acids. We find that there's dramatically low levels of all the amino acids. This is regardless of what they're eating. So they might be eating adequate protein in the diet, whether it's chicken, fish, or vegetarian sources of protein. But as we test amino acid levels in the urine or serum, we find that they are dramatically low. If there's not sufficient amino acids, then all those peptides and neurotransmitters that we talked about cannot be made, and we have out-of-control appetite. So the first point I want to make is adequate digestion with hydrochloric acid is critical for appetite control. I want to take a little time to go into how dopamine and serotonin affects appetite. Dopamine is the pleasure hormone. The whole reward system is based on releasing dopamine, whether it's food, sex, certain drugs. The release of dopamine or the intermittent release of dopamine is the basis for that positive feeling. Serotonin also supports the sensation of satiety. So optimizing dopamine and serotonin are two, not the only, critical components for appetite control. And we've talked about this in the past. Just having adequate amino acids aren't sufficient. We need the cofactors, B6, folate, B12, zinc, as well to make serotonin. Oftentimes, we use 5-HTP, which is the precursor to serotonin. It crosses the blood-brain barrier easier, and we do not have the feedback mechanism that tryptophan has. I use tryptophan for sleep often, but trying to increase 5-HTP, to increase serotonin, 5-HTP tends to have a better effect. I use 50 to 300 milligrams a day in divided doses. It is usually not sufficient, in my opinion, to control appetite, but it is one of the core amino acids. We'll get to the others. I've recently seen patients who, by well-trained or apparently well-trained physicians, are using 600 or more milligrams of 5-HTP, and we've actually seen for some individuals increased agitation and minimal relief from binge eating as the doses get too high. There's also research looking at inositol and bulimia. There's not been a study on binge eating, but inositol is a supplement that we call the second messenger system. So serotonin causes the release of inositol in the brain, and using 12 grams of inositol was particularly helpful in these studies of bulimia. We talk about dopamine. Again, the important amino acid for pleasure. Animals that lack dopamine actually starve to death because they have no motivation to eat. And there are numerous studies looking, again, at individuals that were overweight that had abnormal levels of dopamine in the reward area in the brain. So another one of our important techniques is looking at optimizing dopamine synthesis with some of the precursors, phenylalanine, tyrosine, and the cofactors, B6, folate, zinc. And copper is critical for the transition of dopamine to norepinephrine. So part of our approach is to look at adequate levels of amino acids as well as adequate cofactors to synthesize these neurotransmitters. Talked about, folate. One of the important cofactors, L-methylfolate, is the form that it crosses the blood-brain barrier and is the most helpful. And magnesium is also a cofactor for serotonin and dopamine. Deficiencies are common, particularly those under stress, particularly those that are chronically dieting and using diet sodas, as the sodas cause the phosphoric acid in the soda causes the excretion of magnesium, and we end up with a chronic magnesium deficiency. So in addition to eliminating certain foods or additives like MSG, the amino acids with the nutritional cofactors are critical to support binge eating. Here we're talking about adequate protein, adequate digestion, amino acids, and cofactor supplements. Again, I can't stress enough, everyone's different. 10 individuals with significant binge eating or disordered appetite. One might have untreated ADHD, depression, or anxiety. Someone else might have poor digestion. Someone else might have had a trauma, and which has essentially shut off the digestive system without adequate production of HCl, and many, many other variants. And it could be just pure genetics of decreased dopamine receptors in the brain. One of the most helpful supplements I have found for appetite control is, in addition to utilizing the amino acid precursors, is looking for amino acid supplements that contain all the essential amino acids. And the important point here is that L-tryptophan is included. This is a supplement that we worked on with Pure Encapsulations that New Beginnings has, and part of the critical piece here is it has all the essential amino acids, including tryptophan. You remember, giving amino acid supplements without tryptophan caused relapse in patients with disordered eating. And then we have supplements that enhance serotonin, and this primarily is 5-HTP and inositol, which we've talked about, but also taurine. Taurine is important for decreasing the sympathetic kind of overflow, the anxiety that's associated with those with eating disorders. And enhancing dopamine, we put together nutritional support the precursors of dopamine, which is tyrosine, as well as the cofactors, as well as some of the phytochemicals that keep dopamine in the synapse longer. So in this concept of biochemical individuality, why we have a number of different amino acid products to choose from is that there are many kind of variations, and we can't always predict. This is a case of a overweight male who was put on this dopamine-enhanced supplement for binge eating. Once he stopped eating, he couldn't stop. So his analogy has always been at lunch, if they serve pizza at work, he would have one slice, and then he could not stop. So he would have 3 or 4 slices and then sneak into the lunchroom and finish off whatever was left. Being able to kind of enhance dopamine with the amino acid supplement, within a couple weeks he was able to, and these are his words, able to just have 1 or 2 slices, not feel hunger after that, and not binge. And this individual stopped the supplement, and about many months later, and noticed this same eating behavior returned. There are other individuals that do better with 5-HTP and phenylalanine. This is a product called NeuroPure, also available at New Beginnings. And NeuroPure is important because you have the 5-HTP, but I would say the most consistent amino acid that I have found helpful for appetite control is phenylalanine. Why phenylalanine? Let's see if I have it here. One, because phenylalanine contributes to the release of CCK, and CCK is a neuropeptide secreted in the duodenum to decrease the rate of gastric emptying and has a profound effect on promoting satiety. And what's interesting is anorexics have very high levels of CCK. I believe it's due because of inadequate zinc, so they can't break down CCK. What phenylalanine does is stimulate the release of CCK, which means the brain can be full. So this was a case study of a patient who was found the NeuroPure with phenylalanine to be the most helpful in regulating appetite. Her binge foods was cake and ice cream. She did fine in the day. She would have a sweet and then couldn't stop, and then had more of this large quantities of cake or cookie products. But on the NeuroPure with the phenylalanine, she was able to eat some dessert and not have that intense craving. So again, back to the same slide, appetite is regulated by numerous peptides and neurotransmitters in the brain. It's a very simple concept. There's journals now dedicated to research in obesity and weight control. Every article in these journals over the past 10 years have to do with peptides and neurotransmitters in the brain in animal and human studies regulating appetite and weight. What is missed is that all of these are derived from amino acids. So the core approach that we've taken for many years is optimizing amino acid availability to the brain. And again, not just focusing on neurotransmitters, understanding all the many peptides that are involved. Crack cocaine. It appears that there is a separate mechanism where sugar has a profound addictive potential, and this has been shown in animal studies for a number of years. There are some individuals that are particularly sensitive to sugar, which causes intense release of both dopamine and the opioid system in the brain. That reinforced addictive power of sugar for some creates the inherent weight problems and food addiction. Again, this is an old study, but to repeat it a number of times, the rats that preferred sugar over cocaine, rats were allowed to choose mutually exclusive between water sweetened with saccharin and intravenous cocaine, and the sweet taste of saccharin in this study was preferable to cocaine. There are also studies with various glucose and sugar water. I want to spend a minute to help people understand how important this topic is to me and the thousands of patients we treat, as medication is sometimes needed to control appetite, particularly initially. And it's not the enemy. Frequently for this disorder, binge eating, bulimia, and various forms of disordered eating, medicine is a short-term approach that helps regulate appetite, where then nutritional support can be helpful. Medications have been shown to be helpful for bulimia, but most patients don't have complete reduction in symptoms. We know that the antidepressants, the SSRI, are helpful, but many people forget that these medications are not helpful at normal antidepressant dosages. So they need to be much higher. So the dose that was effective for Prozac was 60 milligrams versus a 20 milligram dose was not effective at all. So we need much higher dosages for the treatment of binge eating and bulimia than we might for depression, a common mistake. Another medication called TOPAMAX can be incredibly helpful for binge eating disorder. It is an anticonvulsant, anti-seizure medicine that's been used also for migraines and been very helpful for addictive behaviors, gambling, sex addiction, and we use it for food addiction. This was, God bless TOPAMAX, was a voicemail I got after prescribing this to an individual who had pretty significant binge eating disorder. There's research to support TOPAMAX and bulimia. It is a it's a generic drug now, so there's not going to be a lot of money put into studies, but significant reduction of binge eating has been shown in good academic research studies using TOPAMAX. TOPAMAX has also been recently used in a medication called Nexia for the treatment of obesity. So it's approved for obesity. TOPAMAX is added with a stimulant phentermine. And I have Mark Hyman's name, who is someone I respect a lot. He's brilliant and he writes well and is educating a lot of physicians and clinicians. But he wrote an editorial, a number of them anyways, kind of thinking that this was such a horrific a drug that's been approved, and that how can we use medicines for weight management or appetite control? And his point is just do it, that anybody can lose the weight and change their diet. And I think this is just so profoundly misunderstanding this illness and disrespectful to so many patients who cannot control these binges or these urges to eat. I use TOPAMAX. I might use stimulants. I don't use this new drug that I think has a new name now. But I just use it as an example of how our medical profession, even our integrative physicians, have such little respect for the biochemistry of appetite. And I'm not recommending medicine be used. I'm recommending that we try as best we can to provide some biological relief for appetite control. And I use this as an example. This was a book, Brain Over Binge, Why I Was Bulimic. And being in the field, treating this for many, many years, I picked up this book. And here is the headline: after 6 years of binging and purging, Catherine stopped her eating disorder independently and abruptly using only one tool, the power of her own brain. Well, that's impressive, and I wanted to understand it. So here's what I understood. to feel, let's make sure I have it here. To feel the urges to binge and not act on them is the quickest, simplest, and easiest path to recovery. It trains the brain to undo the habit right then and there and gradually puts a stop to urges. It is also a foolproof protection against relapse, because if one never acts on an urge to binge, one can never relapse. And I guess I don't have the slide here, but essentially what Catherine describes in one sentence in this book is that her stopping her binge eating was because she took TOPAMAX for 2 years. But she spends 300 pages talking about the power of her own brain, but essentially what she has described is that she took TOPAMAX first, and then she was able to stop the binges. So it's quite a farce and a real misunderstanding, and it wasn't the power of her brain, it was TOPAMAX that enabled her to stop binging. And she says it quite articulately. I apologize for not having that slide. So when we talk about addictions, we talk about this tremendous opiate release, particularly with the casomorphin and gliadorphin, and with those addicted to sugar that produce opiates. There's also individuals that produce opiates in the brain from fat consumption. Then I think it's important to look at those medications that might block that endorphin opiate response in the brain. And naltrexone is a medicine that we use for out-of-control binge eating with very good success. We're blocking the opiate receptors that bind endorphins, regulating the feel-good effects of food addiction. So naltrexone has been looked at for many years. There's mixed results in the studies, and we see that in practice as well. Not everybody responds to naltrexone, but many individuals do. I think that one of the important things to remember is there are different dosing of naltrexone. There's low-dose naltrexone that we use for autoimmune disorders and a whole host of immunological and cancers, and that's 3 to 7.5 milligrams taken in the evening. There's also more traditional doses, 200 to 300 milligrams, that's been studied for alcohol dependency. And then the method that we've developed is taken from the Sinclair method for alcohol use, is using small amounts of naltrexone before binge times. And that could be anywhere from 12.5 to 25 milligrams. And the Sinclair method is a method primarily used in Europe because AA has such a powerful influence here in this country, where abstinence is the only method to treat substance abuse. Well, in Europe, it's often moderation in drinking is sometimes the goal, and the Sinclair method is that using small doses of naltrexone before someone would go out and drink. I've used this in the past in an alcohol treatment program where individuals would have that drink, that alcoholic can't stop, 10, 15 drinks later, quite impaired and intoxicated. Taking naltrexone prior to that, they might eventually, over the course of a month, have 1, 2, 3 drinks and eventually be able to extinguish the behavior as they get control over the addiction. And this is what we also use for binge eating. So we would use small doses of naltrexone prior to binge time. For many patients, binge eating is at a certain time of day. When the kids go to school, in the morning they start. Others, it's in the evening, and the naltrexone could be used just prior to the binge. So many in the eating disorder field are focusing on a mindful eating, intuitive eating, and that is just letting your child or working with your family about learning to trust one's body's cues to guide what you eat. And the exercises usually start with eating a grape and eating it slowly and understanding how that tastes. And I believe this is wonderful concepts, but that is, to me, like asking a heroin addict or cocaine addict to do a mindful drug approach. It's just not going to work. Our patients struggling with addictive food, binge behavior, want to stop, trying to stop. Most of the time, the dieting roller coaster cycle has gone on for years and years, and all they experience is the shame and the guilt of being a failure. So we're looking for biological, biochemical ways to release that out-of-control appetite, to give them some semblance of control. And again, mindful intuitive eating is incredibly helpful for many patients, but for the food addictive patients, it's awful not enough. Food is my drug and purges my addiction. Many patients get into this purging cycle, which also produces tremendous amounts of endorphins and becomes addictive in itself. Here again is another genetic finding that I wanted to kind of end with, looking at a certain polymorphism associated with childhood abuse. There's lots of discussion of where trauma fits in with eating disorders and binge eating. I think the research now points clearly that sexual abuse and physical abuse is not as commonly associated with binge eating, bulimia, and disordered eating, as is emotional abuse. So emotional abuse is highly correlated with eating disorders. And here, this study in the Journal of Psychiatric Research was able to show that there's a genetic relationship here and stress-induced expression of these particular genes and bulimia. So the protocols that we have developed, and we're trying to finish the book this summer to get out to patients, is our typical biomedical testing and personalized supplementation, helping people look for vitamin D levels, B12 levels, dysbiosis, food allergies, all the kinds of integrative tests that we look at that you're familiar with, hopefully, that we would do for any patient. We focus on inflammation because I believe many sources of inflammation cause disordered eating by disrupting brain mechanisms that have to do with appetite. And then the focus of our treatment has been on amino acids, amino acid complexes, free-form amino acids that have the entire complement, including tryptophan. And if needed, medications are not the enemy to help control disordered eating while one learns lifestyle changes. I always try to make sure we throw in the concept by Roger Williams of biochemical individuality. I like his book for the layperson, You Are Extraordinary. It's helping our patients understand that their unique differences make them extraordinary, not deficits. So when we talk about integrative psychiatry, we're talking about multiple areas in physiology. And if we can find the cause or the causes, then oftentimes we can find the cures, meaning you don't have to live with a disordered eating. You don't have to live with bulimia or binge eating. We can treat the underlying biochemistry. I urge everyone, if you haven't heard of yet, the Integrative Medicine Conference. This year it's in Chicago. It's the 4th annual conference. It's an incredible opportunity to be with colleagues who are primarily focused on this work with mental illness. And we had over 200 people last year, and we're expecting more this year. And check out the Great Plains website for more information on this conference. These are ways that you can reach me. The books on anorexia and depression, and the one we're finishing up that is on answers to appetite control and helping patients get off this horrific cycle of disordered eating. I thank you for listening this evening, and appreciate your support and please look up the conference in Chicago.